Ricks, CEO of Life 365, and welcome to Season 2, Episode 8 of The New Normal. Today we'll be talking about kidney care, the use of technology, and new financial models. Before I introduce our panelists, I want to take a minute and thank all the healthcare providers, first responders, school teachers, family caregivers, vaccinators, and many others helping us through the current COVID-19 pandemic. Thank you all for your service. I also want to let you know that everyone will be on mute and that we'll accept questions via chat, and we'll try to entertain a few questions throughout the webinar. Today's webinar will be posted on life365.health website or www.newnormal.buzz tomorrow, along with the audio being available on Apple, Amazon, Google Podcast, and many of your favorite podcast sites. Now, I want to take a minute and introduce you to our distinguished panelists. Dr. Amandeep Khurana is a nephrologist with Southwest Kidney Institute. Dr. Khurana graduated from the All India Institute of Medical Sciences, All India Institute of Medical Sciences, Manalola Azad Medical College in 1997. He works in Phoenix, Arizona, and 8 other locations in specialty in nephrology, and internal medicine. Dr. Khurana is affiliated with St. Luke's Medical Center, Banner University Medical Center, Phoenix, and Cura Health Hospital, Phoenix. And Dr. Khurana, welcome to the webinar, and I'll let you give a little bit more of your update when we get to you as well. So welcome.
Thanks, Kip.
Yeah. Tom Kelly, previous CEO of Aetna, Medicaid, and Life 365 board member. Tom has held a series of executive positions in healthcare, finance, financing, and delivery. Most recently, 2014 to 16, he served as CEO of HealthSmart, the largest independent non-carrier administrator of health benefits. During his time at HealthSmart, the company introduced its My Decision program, the first integrated approach to incentivizing selections of lower cost healthcare services. Prior to his work at HealthSmart, Tom served 2006 to 2013 as head of Medicaid for Aetna and as president, then CEO of Schaller Anderson, its predecessor. During his time there, Medicaid enrollment tripled, and Aetna Schaller Anderson entered 7 new state markets. Earlier in his career, Tom was EVP and CFO of Davita, 2004 to 2006. During his acquisition of Gambro, and founder and CEO of Mercy Health Plans, 1994 to 2004. He began his professional career at KPMG in 1973 to 1993, ultimately serving as partner and national director of healthcare services. During his professional career, Tom served in a wide variety of community leadership positions. He serves currently on the boards of CareSource, Wellbe, a shared decision-making program for surgery, Focus Innovations, a SaaS provider for tools of administrators of home and community-based services, and Foundation for Senior Living. He serves on advisory boards of 6 early-stage health companies. And then Dr. Mehrdad Shafa, Chief Medical Officer of Life 365. Dr. Shafa is the Chief Executive Officer of Medical and Healthcare Consultants, LLC, a Nevada-based consulting firm specializing in managed care turnarounds and implementation of government programs. He has been involved as a chief medical officer and executive director with multiple major insurance companies and health plans in Maryland, Indiana, Texas, Arizona, and California. He has also been the clinical leader of quality improvement organizations and patient safety organizations in Michigan, Indiana, and Arizona. In addition, Dr. Shafa is chief executive officer of Avixena Population Health Solutions. Avixena was founded in 2014 as a consulting firm that offers highly specialized products for population health solutions. So welcome to the panel. It's great to have you here, and very, very well qualified to talk about our topic today. So thank you for being here. So the first thing I want to get into is, I think, there's been changes by CMS to chronic kidney disease and kidney care financial models. They were supposed to be implemented this past January, but were delayed because of COVID-19 to now January 2022. So I'm going to throw this to you quickly. Tom, can you give me an overview of what those new financial models are and who would they be aligned with?
So really for the first time, CMS has made available risk-based contracting for really for people prior to dialysis. They actually have been available for dialysis patients for some time. But for the first time, it really looked at how do we risk contract with organized provider groups and care management companies around the more effective management of chronic kidney disease, the postponement or avoidance of dialysis, and certainly the avoidance of people of the relatively large and unacceptably large group of people who crash into dialysis as part of a healthcare event, which is life-threatening, and which ensures that their need for dialysis and their entry into dialysis are both relatively dangerous propositions. So it's really a tremendous opportunity. Lots of interest in the Medicare Advantage community, which has been probably the most highly organized part of the system in terms of risk contracting and quality contracting with provider organizations of all types. And really, one of those blind spots in medicine. We spent an awful lot of time kind of perfecting kind of the current dialysis treatment protocol. Not necessarily the right protocol in all cases, but really producing a highly effective, low unit cost service of in-clinic dialysis that kind of responded to CMS's question about how do we more effectively deliver this service, but really hadn't addressed until recently how do we actually help prevent or avoid the onset of the disease. And a big undertaking, and an undertaking that was largely a blind spot by the big dialysis companies. So the Davitas and the Freseniuses of the world and and the companies that try and mimic their activities have really focused almost exclusively on dialysis and not really dealt with that issue of how do we help people avoid the onset of dialysis, get there in a healthier state, have better options when they get there, and maintain their independence as they enter into the dialysis space in a more effective way than we've traditionally been able to accomplish it.
So is this, when you're looking at this, is there, I know you want to keep people off dialysis, but, as part of this, you want to try to keep people in the CKD state as long as possible or progress them out of the CKD state, right? But you want to keep them there without going on dialysis or losing their kidney. Is there another side of the equation where they would rather go through and do a transplant sooner if they could?
Oh, we'll let the doctors answer some of the specifics of this question, but for sure, if you're going to make it to dialysis, you want to make it to kidney transplant. And the healthier you enter into the dialysis space, the more likely you're going to get to a kidney transplant sooner. And so tremendous interest. I mean, from the time progressive kidney disease is identified, almost any investment a person can make in improving or managing their health better is going to have a tremendous impact on their kind of life prospects of living independently and their orderly progress to a transplant if a transplant's required.
Yeah, gotcha. So Mehrdad, I'm going to switch over to you really quickly. From your perspective, and then I want to go to Dr. Khurana, your thoughts on, the new financial models that are coming from, CMS and how they could be implemented with a certain, group of individuals that may be CKD or ESRD patients. What you're thinking about the target market, right? But who would benefit the most from these models?
So what Tom said, he elegantly provided the big picture. There are currently 400,000 people in the United States on end-stage renal disease on dialysis. This number is additional 100,000 cases each year. The average cost of a dialysis ESRD patient is between $150,000 to $200,000 a year. And you multiply that number by the number of recipients, and you see that it has become one of the largest categories of expense in CMS budget. There has been glaring issues with qualities and outcome and quality of life for these individuals. About 20% of individuals who receive dialysis, they die within 1 year of that initiation. So the new model is trying to encourage two things. One is improving quality of care, and then the second thing is accomplished by the financial model. The quality of care, there's two things in it. One is there is some benefit enhancement for the individuals, but it primarily is really expanding on the kidney transplant and also transitioning the care from the outpatient dialysis, which is currently 88% of the dialysis received, to home-based dialysis provision. Now, let me just add a few other numbers. About 2.8% of individuals, they undergo a preemptive renal transplant before they go on dialysis, 2.8%. The last statistics I saw, 17,000 kidney transplants performed. And if you increase that number by 20% miraculously within 1 year, there are 93,000 people awaiting kidney transplant in the United States right now. So I don't think moving the patients to the from dialysis to transplant is going to have a very early impact. This is going to take several years for us to see any change in that direction because of the backlog. So what it really goes to, it is a financial model. The financial model that actually is very convoluted, how the centers are selected, how many patients, how patients are attributed to them. But there is basically capitation, combination of capitation and global risk payments to the providers. Now, the primary driver of what's going to happen is a change in financial model. That is what it is, because transplant, in my opinion, humble opinion, is not going to have any immediate impact. So what does it take to move patient from outpatient to home-based setting? Number one is you need to have patient-centered care. You need to start attending to social determinants of health and technology. Without these three elements, this is a no-go. We must have these three elements in order to make a dent. So provision of technology through any type of use, particularly remote care monitoring, is going to be mandatory if this is going to make any difference. So I'm going to stop and then wait for later. Yeah,
thank you, Mehrdad. So Dr. Khurana, I wanted to ask you a question really quickly. Given all what Tom and what Mehrdad has said, let's get down to the practical use in your practice. How are you preparing to be able to implement these new models of care with your patients in your practice?
Right. It's a great question. So I want to pick up on something what Tom mentioned earlier. So I think that we need to make sure we delineate, there's two different business models we're talking about. There's a financial model that applies to ESRD patients. It's been in existence for a couple of years. It's called the ESCO model. And that's the one that's been driving patients to more at-home dialysis. But the new model that we're talking about, the one that starts next year, is the CKCC model. And that applies upstream. So the first time, we're basically we're able to apply some risk contracting to the CKD space. So sort of two different models that we're talking about here. The big difference in my mind is in the ESCO space, the driver has been a hospital care system and a dialysis, an LDO. So Davita, Fresenius of the world, etc. Whereas in the CKCC model, for the first time, we're actually putting the physicians who are most aligned with the patient in charge of the risk program. So that's sort of one issue I wanted to point out. The second thing I wanted to point out was, we're talking about the cost of care. So it's the average cost of care in a patient with CKD stage 4 is about $45,000 a year. The average cost of care of a patient who's on dialysis, depending on the age, is between $85,000 to $129,000 a year. So prolonging the patient in CKD by whatever means it maximizes the patient's quality of life, and there's a big financial impact to the healthcare system. So sort of a win-win. But once you get beyond that point, so that's sort of a no-brainer. That is clearly where we are. Once you cross the threshold of needing some form of replacement therapy, then the question that you mentioned, what's the form that we pick comes into play. And there clearly the answer is transplant. But as Mehrdad mentioned earlier, the flow limiting factor there is the availability of organs. It's not the patients being listed. So right. We can list more patients, we can maximize that, but it's really numbers aren't going to budge because of that. That's a different discussion completely. So if we talk about both the ESCO and the CKCC models, I think the important things there are anything we can do to triage patients, to proactively manage these patients are what's going to drive down the cost of care and improve outcomes. And that would include, so technology is going to play a big part of that, clearly.
Yeah, one of the things that, I think I mentioned to you as well, is that, I'm not going to say fortunate, but I've had exposure to friends that one friend that's actually lived with her kidney now for most of her life, one kidney, and she's in a CKD state, but she actually through a diet and exercise, and really keeping track of her medication and her vital signs on a regular basis, she really knows her numbers pretty well. She actually can keep, that kidney going on a regular basis. It may get to, a function level of 44 or 45, and it may come down in the mid 30s, which panics her, right, on any going basis. And I've had a friend on the other side that had 3 kidney transplants, and was doing hemoglobin dialysis at times. He was doing peritoneal dialysis at times. And I know the quality of life between these individuals. I mean, when he did peritoneal dialysis, he felt a much greater will to participate in society because he could do it at home and he could dwell at night versus transportation issues of going to hemodialysis. So really quickly, Dr. Khurana, from your standpoint, if somebody does get to the ESRD stage and then goes to a dialysis stage, aren't we a little bit behind other countries where we do more hemo than peritoneal? And do you see that changing?
Yeah, absolutely. So most countries do a lot more peritoneal dialysis and a lot more home hemodialysis than in-center hemodialysis. Part of this is legacy. We've built up units that are capital intensive, and sort of that's what our model's been. The second has been how a lot of this is being reimbursed. So this isn't driven by patient preference. This isn't driven by provider preference. It's been driven, a lot of it's been driven by the way reimbursement's been done. For example, home hemodialysis, if the reimbursement is capped at 3 sessions a week, that sort of makes the whole, project less viable. But having said that, one important secular of the new care models and the new financial models are that there's more leeway to pick and choose what we want to do. And clearly, peritoneal dialysis, where, as you mentioned, the quality of life is way higher, but also the cost of care is lower, right? The average patient on hemodialysis, if you look at ESRD numbers, is about 85 to 90,000 a year. The average PD patient costs Medicare about 65 to 70,000 a year. So there is clearly about a $10,000 to $15,000 swing in cost. So again, it's one of those win-win situations where, if we do more PD, everyone comes out ahead.
And do you, when you are recommending people to go on dialysis, do you have a voice in going through and saying where they go to hemo or where they go to PD, or how is that determined?
It is ultimately a patient choice. So all we can do is educate the patient, and clearly the patient has complete control over, what modality they pick, where they go for dialysis, et cetera, et cetera. So the role that we as providers play is in educating the patient, making sure they're fully aware of their choices and fully aware of the risk and benefit of each modality before they pick the one they'd go with. And as I think and someone else mentioned, I think Tom mentioned that a big part of this is crashing into dialysis. So the the mortality is pretty high. It's it's front loaded in the first year of starting dialysis, but even within the first year, it's actually front loaded into the first 3 months of starting dialysis. And there's a lot of variables that drive that, the mortality and the cost. But the biggest factor there is people not being prepared for the transition.
One of the things that I'm going to go back to Tom here in a second, but one of the things that we saw when we're kind of graphing cost along the way is that intersection when people don't know that they are having kidney issues or they're a CKD patient, the cost of care spikes up because they may be going into the emergency room or going in the hospital until they're properly diagnosed as a CKD patient and properly treated as a CKD patient. There's been, I've read studies and there's been conversations around, and I don't know how much you get into RAF scores that are out there, they're risk adjusted factors, but that has to do with compensation more than anything else. But properly getting somebody diagnosed, I know that one of the ACOs that we deal with, their biggest concern is as they're spinning through their database and seeing their patients that they may be treating people that are really CKD patients, but they're not able to identify them and get to them as a CKD patient. So are there things that you work with other local practices to be able to help identify from a referral perspective or them referring to you, people that may be potential CKD patients in their population?
Absolutely. That is something. A lot of this is education. A lot of this is data mining. But yes, that is clearly something that we want to do and we are doing.
Yeah, I know you take referrals in, but I didn't know if there was the data mining part of it. I didn't know if you worked with them to go, are they on metformin? Have you tested them for GFR levels, right, or creatinine levels or other things that may be an indication that they need to be referred to you on a regular basis, right, as well. So you can look at that spike. One of the things, Tom, I wanted to go back to you really quickly, is there's organizations that are starting to pop up around that are very specifically taking on large populations of CKD patients, and maybe it's just CKD, but maybe it's ESRD as well. You don't need to name the organizations, but because I know a lot of them that are around. But is this going to continue to grow as a model where these organizations are very specifically going in to contract with payers, right, or CMS to be able to take care of certain patient populations in CKD?
No, I think so, absolutely. It's if you look at kind of the neglected population in American healthcare, it's people with chronic disease that tend to go through a kind of a constant progression of severity, and who were late really to aggressively interact with, right? So the fact is, the first time this sign is present, the more engaged you get, the more the patient gets engaged early in the process. Just the postponement of dialysis and a much healthier life during that progress and a better ability to deal with dialysis are all in the cards. And so how do we put the time and energy in very early in the process to say, you have choices to make here, and those choices are going to have a lot to do with the quality of your life. And we're ready to help those choices, because you see the biggest drivers in the cost of American healthcare, progressing chronic diseases are right at the top of the list. CKD is certainly one of those. So we're going to look for expertise, and this particularly nephrologist expertise, to say, how do we do this best? And by the way, how do we get paid for it? Because if we do a particularly good job for it, the fee-for-service world is not really designed to pay people for diagnostic and maintenance kind of work. They love paying people for interventions. They hate paying people for using their heads. But the fact is, the opportunity both to give people a better life and to save significant dollars in the healthcare system is about using our diagnostic and early intervention capabilities a lot more effectively, and paying the people ready to organize that activity and do it well.
Yeah, so I've studied several organizations that are out there. It's public information. I've noticed companies like Strive Health that just got, I think, what, 140 or 150 million dollars, right, in funding in their current round. What is something like Strive's value proposition? Is that value proposition to the payer, right? From that, or what is their underlying value proposition?
Well, the underlying value proposition is really both to the payer and to the patient, right? So it's, can I put you in an organized system of care that in fact is going to do a better job for you and ultimately help you avoid costly and typically disabling medical interventions over time, right? So people are going to do that. What these new companies provide is, one, we've got now not only really excellent digital technology that allows us to stay in contact with the patient, we've got the ability to understand what the home environment is, we've got the ability to build both education and intervention at home, and thereby avoid more costly interventions. We've got the ability to link the nephrologist into a system where their talents are used at the very best level, right? That there are management things that can and should occur that don't need the nephrologist's day-to-day attention, but need the leadership, the thought process, and ultimately the care capacity of the nephrologist. So, and the system historically hasn't been organized to do that very well. The digital stuff is new, but the fact is the system historically has scratched what itches, which are people who showed up in emergency rooms, right? And inevitably, we've really put people in a much more risky position by waiting for care than we ever should have. And there are tremendous benefits both for the patient and the payer for intervening sooner and more effectively.
So keep walking me through the model just a little bit on like Strive or the other companies that are out there. Are they very specifically going after preventative? Are they going after CKD to try to keep you off dialysis and ultimately a transplant, or do they deal with ESRD as well?
Well, it can deal with both, but you'd say the ESRD world is pretty well organized and certainly dominated by a small number of groups. So I think you need pretty powerful nephrologist involvement if you want to change the ESRD experience. But they're saying, listen, there's a gap in care here, and it's a multi-year gap in care while somebody's suffering from a systematic slowing of their kidney function and a systematic increase of the risk to them, to their health. And that's where we have to intervene in that multi-year opportunity to say, how slow can we make it go? It's liable to keep going almost no matter what, but it can go slow or fast, depending on what people do and how good the care is that they receive. And we can get them to dialysis in a non-critical state. So in fact, they have better choices about the treatments they select. Much more likely if somebody's healthy at the onset of dialysis, they're going to do peritoneal dialysis. If they crash into dialysis, much more likely they're going to go directly to clinic-based dialysis, right?
I got you.
So your choices are going to be much influenced by how aggressively you manage your own health and how aggressively you accept the tools that are now available in the health community to help you get there. And it's a hard thing to do it all by yourself as a CKD patient. And I think a tremendous opportunity basically to be engaged, not only with other people trying to wrestle with the same issue, but people with tools and reminders and ability to interact on a regular basis to help you through the process and avoid the lapses in good behaviors or care that really can lead to very dramatic declines in health.
Yeah, I see, and obviously I'm not a physician, but I see these two really dramatic areas for intervention. And this one is when you're not diagnosed quite yet and you're spiking to really do a lot of costs. Getting you diagnosed is the first thing. And then the second thing is trying to, smooth out and prolong, the CKD cycle of it as long as possible to keep your kidney as long as possible but giving you the tools to be able to do that, right? And then if you need to, smoothly transition you over into, into the dialysis phase, right, of it as well. So I totally get it. Now, one thing you did say was talk about technology, and that's part of the reason why we're here. So Mehrdad, I wanted to ask you a question really quickly. So when we're dealing with all this, and I'll go back to Dr. Khurana as well, what data is important, right, to be getting from the home of the patient on a regular basis? That is a CKD patient or a pre-diagnosed CKD patient.
Sure. So Kent, screening is a critical factor here for CKD. CKD has 5 stages. It doesn't happen overnight. And one of the areas that there's great opportunity for nephrologists to educate primary care and enforce the message that CKD monitoring should be part of the patient monitoring ongoing, starting at a very early stage. The second group of people that I think should be very closely monitored are people who have known major risk factors, diabetes, hypertension, people who have had significant diet exposure for the imaging procedures, etc. Those people, after their initial procedure, they need to be very closely monitored because there are significant opportunities, risk associated for those individuals. But what you really need from the perspective of monitoring individuals is based on what are the initial findings. If the patient has stage 2, I don't think you need any home monitoring at that time. It's just the regular visits with PCPs and maintaining a normal blood pressure, vital signs, and avoiding of certain nephrotoxic drugs and everything else, patient education. That is what we need. But as you have got now patients who are homebound and they have really advanced disease, now you will need a lot more information. You need kidney disease affects every single part of the body. So you need whole system monitoring, vital signs. You need repetitive lab tests, urine function tests. And then I'll let Dr. Khurana answer that. But I think the opportunity here is that we really need to use technology and to screen people for chronic kidney disease. And as a patient is diagnosed with chronic kidney disease, attention to social determinants of health is critical because patients' ability to cope with the disease, doing a home assessment, identifying what other attendant social factors are involved, collecting those will become critical in managing people.
So in the system Avixena, you have like 30, 35 different protocols that are there, and it looks at social determinants of health and risk assessments, and readmission reoccurrences. But you have a new module that's the chronic care or CKD module, correct?
That's
so
correct.
What's the attributes of that CKD module? Why did you develop a module?
Well, because of the nature of the beast, that this is a severe condition and it is very prevalent and it's quite costly. It meets all the criteria and there is a significant opportunity for improvement. So our app actually has 2 components. One is for screening, and the screening can be done by primary care. That screening can be used to generate the referral to the nephrologist with information all under one roof. So there's no information lost during the referral process. And the information that is generated by the nephrologist assessment can be easily shared back with the referring physician or used for longitudinal monitoring of CKD. What we have tried to do is capture all ends of the CKD care from multiple providers and transmission of information under one roof. The app is based on is evidence-based and is based on the recommended best practice for CKD screening and management.
So would that app actually just bolt onto the front end of the electronic health record?
We have addressed that issue, and it can easily interface, and the data can be extracted and transmitted to any other electronic health record or databases, and can be used by multiple providers, different sites, all at the same time. That is correct.
So let me go back over to Dr. Khurana and ask him a question on this. So we've just talked about, providing data and technology and solutions. I would assume you're pretty busy in your practice on a regular basis from that. And most things I hear is that physicians just don't need a lot more data that's out there. How will you deal, or how do you deal with patients that are on the outside that have critical data for you to look at on a regular interval?
Yeah, that's a great question. The issue is signal versus noise, right? What you want is signal. You want the right bit of information at the right point of time to the right person, as opposed to generating a lot of data, which is just noise. And that is an issue that really hasn't been properly solved yet. I think that is definitely one of the big issues with chronic care management. And there's different ways people have looked at this. One way is to sort of look to go on the question you're asking, which is have defined episodic care, right? So we have multiple episodes of care, have more frequent interactions, and then we'll have some data points in between interactions. The second is to go to a more population-based care, which is when you have a cohort of patients that you manage collectively, you triage them, and then have some way where the appropriate information sort of rises through, is filtered through to the right person. And I think that is the care model that's going to be developed once the new financial model goes into play. So I think that's still a work in progress.
So a model like a Strive that's out there, I don't want to keep on, because there's other ones, Cricket Health and IRC and American Renal and all those guys that are out there as well. Is a model like, let's just take Strive, is that beneficial to you, where somebody on the outside is kind of reviewing your patients on a regular basis and engaging them on a regular basis, and only bringing the signal to you and not the noise, right? Don't need to show you when to intervene. You need to intervene.
It can be, but I think a lot of this is going to be developed in-house. Will sort of be done in-house by the nephrology programs. So I think one of the big model changes in the ESCO, for example, was that it put the large dialysis organizations and the hospital systems in charge, essentially. Whereas with the CKCC model, it's the nephrologist now in charge. So all of this can be developed in-house by the people that are actually responsible for providing care. I think that is exactly what's going to happen.
So let's talk about that a little bit. So when you talk about it being developed in-house, are you looking at utilizing your own resources that you have as far as nurse practitioners and MAs and others that are available to you to be able to be calling on patients on a regular basis? Are you going to be looking at implementing technology so you can get data in that goes through a noise filter of some kind? How do you see probably implementing it in your practices?
Absolutely. I think both of those ways for sure. And I also want to point out that, we talked about information that we gain. So the first step is just getting the information that we need, stuff like vital signs, weights, urine outputs, things of that nature. The second is labs, sort of higher level information. The third bit of information, which is what we really want to get to once we can leverage all this data and AI, is to have some way so you can actually triage patients and sort of pick out patients that are going to need more care in the future. And that's sort of what we're heading towards eventually.
Right. So it's not just a system that is you're setting alerts and you're setting parameters. You're looking at systems that are intelligent systems that can point out trends to you as well, or recommendations to you, right, on that patient.
I think that's exactly how it needs to be. You have a significantly large number of complex patients with multiple issues going on. This does require a comprehensive systemic solution.
Okay, I get you. So Tom, let's go back to you really quickly as well. I kind of want to go through where you see technology playing a pivotal role going forward as well. We've talked about Strive and their care part of it. Where is the data and technology the most important in these practices?
Well, and I think Dr. Khurana did I thought, a very good job of talking about that. He's looking for predictive analytics, right?
Yeah.
And really the question is how do we, who becomes the collector of data and the original screener of data for predictive analytics? And certainly, each of these care management company intends to do that. And I also say certainly well-organized nephrology practices with solid organizational resources and skills can do it for themselves as well. So we now have an open market that says, one, for the first time, somebody's going to pay for this. And two, we're going to see alternative models in terms of who are the leaders of this activity. Although I think the type of data to be collected, its frequency, ultimately even the predictive analytics will be quite uniform. The question really becomes how many moving pieces do we have? And I think the number of moving pieces probably has more to do with size of practice and organizational capacity than it has to do with anything else. If you're a smaller practice, you're much more likely, I think, to partner with an organization that's going to do this at scale for many practices. If you're a larger practice, I think you're going to be more tempted to do it yourself. So I think we'll see both models out there. I think there's still some advantage to be in a practice that's doing it for yourself, so long as you can kind of deliver the organizational work that's needed to make it happen, right? But there's a lot of cleverness out there in these new care management organizations. And even if you're going to do it yourself, you're going to want to learn from the kinds of things they try, and particularly the things that prove themselves more successful.
Well, talk to me a little bit about the cleverness, right, from that. I mean, it's interesting, and one that we've had experience with a little bit. They weren't even, going to start with taking biometric readings. They just really wanted to start engaging the patient to be connected, right, from that. So can you talk a little bit about that cleverness? Yeah.
Well, so the first thing is if this is going to work for any of us, the patient has to be engaged, right? If you want to know what their weight is every day, they still have to step on the scale.
Yeah.
They still have to respond to a reminder that they haven't stepped on the scale yet today.
Right.
Get to those patients where fluid buildup is a problem, they've got to be ready to take an action if the fluid buildup is significant. Right. It's until we get better about lab tests, they have to go through all that painful crap of having to go and get their blood tested externally, right? We're going to eventually be able to do that in the home, but it's tricky or expensive these days. So it still happens. It still happens in laboratories. That I haven't met anybody yet who really likes going to have their blood drawn and sitting in a big room and waiting in line and waiting for somebody to read their name badly or and be called up for their turn. So it's so somebody who's going to organize that, and of course, engagement is what it's about. In chronic disease, it's about, does the patient understand their role in this? Are they going to be actively supportive? And are they ready to make some of the lifestyle changes that really are critical to slowing the progress of the disease? Right. So it's here you typically have multiple chronic diseases. So all too often people are choosing one or two things to do that address that they may find easier to do, even though maybe there are 5 or 6 things they ought to be doing based upon the diseases they have present. And so it's how do you kind of reach into the home? How do you have a regular contact with that member? And how ultimately do you influence the member to take a lot more ownership of their health than they would otherwise?
Yeah, it's interesting. I won't get into the details of it, but we are working on a major initiative with a testing lab that is has an ability to walk through the front door, both digitally, right, and physically, right, through the front door. And while they're in that home, what else can they do, right? What else is available for them to do? So Mehrdad, let's talk a little bit about that. Let's, you know, in Arizona, it's a little bit different. You can order your own panels and blood draws and everything else from it as well. But if a phlebotomist goes into a home, or maybe a med tech goes into a home, to be able to do a blood draw, especially if it could be around CKD from that perspective, what other things could they do while they're in that home to help out from the CKD side of the equation, or the kidney care side of the equation?
Okay, sure. As you're transferring care from outpatient to home-based care, first priority would be as Tom said, do a patient engagement survey to ensure that what is the level of engagement and where the patient and the caregiver stand. Second, performing a home safety and security assessment to ensure that the home environment is safe and conducive to delivery of care. Some basic things, sometimes availability of electricity or basic amenities of the home and the surrounding environment. The other factors that you have somebody in front of the patient, and that is doing medication reconciliation. You have now access to what patient is reporting, but actually what exists in the patient's residence. Then other testing that needs to be done, either drawing lab. If they are with the new technology that is available, you could perform an EKG or obtain other lab results, pulmonary function test. Getting inside a patient's home, it provides an incredible value proposition of getting inside to what is not known right now, widely not known. And then developing a care plan and assessing a real-time psychological status of the individuals and the caregiver and family members is valuable. One other tool, I'm sorry, Tom, I have to, Kent, I have to add this. We have developed an app called Follow-Up App that is when a patient goes from one setting to another setting, let's say post-discharge or even post-office visit. Studies have shown the vast majority of people forget and they cannot recall a lot of instructions provided to them, and more instructions provided, less the recall ability. That app that we have developed actually alerts, prompts the patients to report vital signs, their biometric tests, weight. You can have vital signs, as I said, signs and symptoms, and any other thing that has changed or you want the patient to report back to you. That needs to be supplemented as, even though patient, you have done all the screening, you have done all the assessment, you still need patient to be engaged and report their symptoms, because that cannot be substituted by any AI or provider engagement. Patient has to report those back to the provider.
Yeah, I hear what you're saying. I'm a big believer that with the evolution of these massive telehealth channels that are emerging, that are going to turn into pay providers and, you know, disintermediate the third parties in between and really get closer to the patient, that the mass value proposition coming is going to be the people that step through the front door of the home, whether it's physically or electronically, as part of that. And the other part of it, I believe that the subspecialties or the specialists that are out there, like endocrinologists and cardiologists and nephrologists, a lot of people, I'm probably going to make people mad, but a lot of people will give up their GP, their general practitioner or PCP, in lieu of taking somebody from a telehealth visit. But they will not give up their subspecialty. They will not give up their specialty doctor because, you know, it's a cardiac issue, or it's a nephrology issue, or it's a diabetes issue from that. So I think the ability for us to walk through that front door and collect other information is incredibly important. And that's why I wanted to go back to Dr. Khurana really quickly. You know, how important it is to you to have eyes and ears into a patient's home from that. Are from your practice, are they always having to come in to the office to meet with you, or do you also have telemedicine or telehealth visits as well, or physical visits to the home or care facility?
Well, like with everyone else, we all now have telehealth, capabilities, thanks to COVID. And the answer to your question is sort of nuanced, which is that there's a lot of data we would like to get. Unfortunately, a lot of this can only be had when the patient comes to the office. A lot of this is driven by the way reimbursement works, unfortunately. And as that changes, hopefully, we'll start to get more data outside of the office visit as well. As far as the data goes, clearly getting a one-off, for example, blood pressure or a weight is an example. Getting a weight when the patient comes to the office, or getting a blood pressure reading when the patient comes to the office is suboptimal. Ideally, you'd like to get more blood pressure readings, sort of get more data points, and get a higher quality of data points. In other words, see what the patient's blood pressure is when they're in their, natural milieu. So clearly, I think the more high quality data points we can get, and use that to make appropriate decisions, I think the better off we are, and the better off the patient is.
Is that data that you look at for trending, or is that data that you would look at to respond to in real time or near real time? Because I know that is a concern of people that are new, potentially, which you're not, but new to telemedicine or telehealth or remote patient monitoring, because so much data is coming in. Do they have to respond to it as it comes in? Or do you see it going into analytic systems? I mean, AI and analytic systems need data on a regular basis, but I always say doctors don't, right, on a real time. Are you concerned that data does come in real time as a double-edged sword, and you're not there to respond to it?
Yeah, no, absolutely. And that is, like I said, like I mentioned before, I think that is definitely a work in progress. I think the idea that we have data, so that the short answer is both of those things. In other words, yes, looking at weight as an example and using that as a trend line when the patient comes for a visit and per episode is clearly valuable. But what is even more valuable is to preempt a lot of things that you can do by looking at triggers along the way. That part is something that's still that needs to be worked. There's a lot of kinks in that process, but eventually I think that is where we're heading to.
Yeah, it's interesting, and I know we got to wrap up here in a few minutes, but the use cases I talked about, one, a friend, an older friend of mine that, actually has been able to save her one remaining kidney for the last, 40 years or so, and keeps her numbers in. She uses our system, she's able to track her blood pressure. She correlates it to the medication she takes. She was able to actually spot problems in her system and adjust it based on it, but you weren't seeing data on a regular basis. She was trending and doing self-management from it. My friend that was on PD, he loved it from the standpoint that he could work during the day, he could dwell at night. And he's one of the ones that are actually inspired remote patient monitoring from our side, because we wanted to look at things like temperature, right? We want to look at blood pressure. We wanted to look at weight. Is he retaining fluids? Is his blood pressure elevated? Does he have a temperature? Is peritonitis setting in from that as well? Because, and glucose as well, because he was diabetic from that. And those were actually self-management, but they also got fed to a portal that if somebody saw a spike in weight or a spike in temperature, that they would make a phone call to him and intervene on a regular basis. Is that where you're kind of headed from a data perspective, you think?
Yes, I think we will need a system that's reliable, that can reliably filter out the signal from the noise. We don't quite have that yet, but that is clearly what we're heading towards. But the point I was trying to make was that even without that sort of endpoint, or even without reaching that goal, even the intermediate endpoints are useful. In other words, even having blood pressure, on an episodic basis, even seeing weight on an episodic basis, is more useful than not having that information at all. So, in other words, it's a sequential, process.
Yeah, I get it. All right, well, we're going to wrap up very quickly, but Tom, I want to go back to you. from what's the biggest, kind of takeaway from happening in January? How would organizations start to prepare for this new financial model that's being put in place?
So, I mean, as is true often when these programs start, the first advice is go for it, right? I mean, the opportunity is there. We know there's a lot of money to be saved. There's a tremendous amount of improvement in people's health status that can be achieved. So there's going to be easier money at the front end of this program that will be there as it progresses, which means get engaged early. You certainly are going to be very aggressive shoppers for these kind of services, both among the MA plans and among people who operate MA plans and other kinds of plans. And I'd say lastly, and I don't want, people shouldn't leave out of this, what's your family caregiver strategy? Because all that stuff we need for the member who wants to be an engaged member, we need for a family caregiver, whether they're there in the home or they're someplace else. Right. And again, the digital stuff gives us great ability to keep, a remote son or daughter, uncle or aunt involved in the care in a way that they've never had the opportunity before. And that says, how do we help them help their loved ones make good decisions? How do we help them, make them part of that process of people changing their behavior to do better, right? And all too often we forget about that family caregiver, and we don't think about how do I put the very same tools in their hands to be a real assistant in the process.
Yeah, it makes a lot of sense. The other thing that from just a looking forward perspective is this as well, we are getting a lot of inquiries from care organizations, right, that provide care in kidney care that's out there. That's why I wanted to have this program this afternoon. And they need to link up with the technology side of it, right? It's the peanut butter and the chocolate kind of coming together. That's the value proposition, to be able to get the data, the right data, I think you guys already said it, at the right time, aligned to the right patient for the right outcome at the right cost, right, to do that. So technology going alone in this space is probably not the right thing to do. Care going alone in this space is probably the right thing to do, but those going together, it probably is a great value proposition, right, I believe. So Mehrdad, just wrapping up from your side, right, as well, just some parting words as far as, the new financial models that are coming.
Well, this is a great opportunity because it has been said that now there's a model to pay for managing before ESRD, and now there's other options available for not to put people on dialysis. So these great two changes will foster great change. And again, in my opinion, you need three things. You need patient-centered care, social determinants of health, and application of technology to make this thing happen.
Well, thank you so much. I want to thank everybody for attending this afternoon. And I want to take a minute to thank our distinguished panelists, Dr. Amandeep Khurana, Dr. Tom Kelly, and Dr. Mehrdad Shafa for your participation and great insights in kidney care, the use of technology, and new financial models. I'm also sorry that I think we got to all the questions that were out there, but if there's any other questions, please just email me directly. We'll post the video on life365.health and www.newnormal.buzz website, as well as your favorite podcast sites. So please be safe and healthy. We'll be hosting the next edition of The New Normal on June 2nd, 2 weeks from now at 1 p.m. Pacific time, with the subject, The Whole Person Solution, Personalization of Healthcare to Meet Individual Needs. So have a great afternoon, and thank you for attending.
Thank you.
Thanks, guys.
Good day.
Appreciate it. Thank you, Dr. Khurana. Thanks, Tom. Thanks, Mehrdad.